Hello and welcome to the APAP podcast. I'm Corinne Young, your host today and the president of the Association of Pulmonary Advanced Practice Providers. And today we are going to be talking about MAC, mycobacterium avian complex, or MAI, mycobacterium avian infection. And with us today is Jennifer Faber Gerling. She completed her undergraduate nursing at the University of Rochester in Rochester, New York. She first functioned as a staff RN with a focus in pulmonary care. She also obtained experience as an operative RN in cardiothoracic surgery case management. Her completed first master's degree was as a clinical nurse specialist, a CNS, at the University of Colorado College of Nursing, and served as a CNS educator supporting RNs working with pulmonary hypertension, lung transplant-acquired infections, cystic fibrosis, and thoracic surgery. Jennifer has been practicing at National Jewish Health since May of 2008 in the Division of Mycobacterial and Respiratory Infections, during which she completed her second master's degree as a nurse practitioner at the University of Colorado College of Nursing. In this role, she works with a collaborative team of physicians, respiratory therapists, dietitians, and nurses to service a primary outpatient, it is outpatient, but also out-of-state patient population with pulmonary and extrapulmonary mycobacterial infections, and bronchiectasis as well, which I think bronchiectasis could be its own podcast as well. So thank you, Jennifer, for joining us today to talk about this interesting bug that all kind of has us scratching our heads a little bit when we see it.
Now, Corinne, thank you for that great introduction. And I'm certainly very embedded in the mycobacterial world and very passionate about that. Welcome any opportunity to interface with my peers to help assist with this sort of complex and very chronically ill patient population that at times can be very challenging and also time consuming, with the amount of education and support that there is required to help them manage this chronic lung disease as well as their acute treatment of their mycobacteria. Mm-hmm.
And I think you hit it right on the head there. It's not just an infection, but it's also a whole disease process and other diseases that then start accompanying it as well. So very, very complex patients. Okay, well, let's jump right into it and start with the bacterium itself. Can you help us understand Mycobacterium avium a little better?
Sure. And so Mycobacterium avium is a non-tuberculous mycobacteria, or NTM. It is a species that is part of the Mycobacterium avium complex. And that's really important to note because we've changed terminology a little bit over the years. All NTMs, including Mycobacterium avium, is found in water and soil sources. And that includes things that are in your household, like your shower heads, your drinking water, potting soil, dust, things like that. So it's all around us in our environment, and that can be really, really overwhelming for patients. And, they try to protect themselves or isolate themselves from all of those sources. And realistically, you cannot do that. So it is very overwhelming to these patients. And I think it becomes a little less about the environment itself and a little bit more about what is it about that person's lung immunity that they can't handle it, where someone in their household who may be doing some of the same things or exposed to some of those same environmental factors are fine. There's also approximately 200 different species of NTM, and that's growing. And these are identified as opportunistic pathogens. Mycobacterium avium is the most common pathogen of NTM lung disease. And what we're seeing in the United States is that it's isolated in almost 80% of the cases, and it is on the rise. Along with that, we're managing a chronic lung disease process. We're treating for an extended period of time for these mycobacteria, and we're also seeing an increase in our healthcare dollars that are being associated or consumed by this process as well.
Any idea behind why it's on the rise? Any theories?
I think partially, education is promoting that. We certainly, since we're a referral center, do a lot of education with patients, There's a lot of support, NTM support groups across the country. So I think just awareness, global awareness. This is not a state reportable or CDC reportable incidence. They give averages. It's not like TB. I think just that global awareness and education that's being provided to providers and patients.
Now we see MAC, MAC, and MAI used commonly in literature or even maybe with the physicians that we work with that are seeing these patients. Can you help us kind of understand those two terms a little better?
I can. I think Dr. Daly, who's he's the chief of our division here at National Jewish Health, stated it best by describing the term MAI as an old term. And it was utilized when we only thought that mycobacterium avium and mycobacterium avium intracellulare were part of that MAC complex. Now we understand that within that umbrella term of mycobacterium avium complex, there's actually 11 different species. So we're moving away from identifying the MAI and giving it its own name of mycobacterium intracellulare, if that makes sense.
Yes.
So we have the mycobacterium avium, and we now have mycobacterium intracellulare, and they make up the complex of mycobacterium avium complex.
Got it. So if you use
yes.
MAI,
and
then you're
they're
OLD.
both identified as slow-growing mycobacteria. And in humans, they are the two main species that make up that mycobacterium avium complex. The species are really difficult to differentiate within the lab, and we're not really sure what the clinical significance of identifying them as different species are yet, and they're ultimately treated the same way.
Okay, good to know. Good to know. All right, that helps us. So these patients tend to present like all of our other respiratory patients, coughing, usually some sort of persistent cough or maybe chest image findings. I know probably by the time you see them, you're probably seeing them when they're more aggressive cases. But what should community practice APPs be looking for when thinking like maybe I should screen this patient for mycobacterial disease?
Sure. I and the way I interface with patients, I talk about the 3 factors that we consider in determining whether a patient needs to be treated for their mycobacteria or not. And just as you alluded to, Corinne, some of the symptoms have overlapping significance with other disease processes. So there is a high percentage of patients that go a long time with not achieving a diagnosis. And that could be years. But some of that is the clinical presentation of the patient, that chronic cough or recurring cough. Having a cough for over a year is not normal. Sputum production with this cough. And that can be, some patients do produce sputum, some patients don't. Dyspnea. Most patients describe their dyspnea, not all the time, but they notice it if they go up an incline or climb a flight of stairs. And that also could have implications with other things as well. Hemoptysis, blood streaking, weight loss or a loss of appetite, fatigue, chest pain or chest discomfort, and sometimes fever, although we don't usually see that primarily as a result of mycobacteria. But as you can see, those symptoms or list of symptoms are pretty vague and could have implications for other disease processes as well. The next thing we talk about is that microbiologic data. What are you getting from sputum sources or BALs in the patient? The criteria for diagnosis of a mycobacterial infection is to have 2 separate expectorated sputums, one or more BAL samples or tissue sampling. And I would say I want to be thoroughly convinced that there's mycobacteria there. I want to see it, the same species, twice before I even consider treatment. And then the last thing is radiographic data. You can't necessarily see a lot of detail on a chest x-ray, but that may be the first indication that there's something abnormal within the lung. And typically it's a high resolution CT of the chest. Most of patients will present, if you get them early on, as nodular bronchiectatic disease, but they also could have cavitary lung disease. So that also is a factor in the decision making. Do they actually have radiographic findings that could be consistent with a mycobacterial infection? Now, it's not always so cut and dry. You have to have buy-in from the patient as well, because when we initiate treatment, that's a long haul for this patient. We have had patients, yes, they meet all those 3 criteria, but, we're kind of on the fence. We could treat, we might not treat, but I've had, for example, a working adult who said this fatigue is so debilitating that I just want to give it a try, or this cough, is just, it's so disruptive in my day-to-day life. I just want to give it a try. And with close surveillance, we'll pull that trigger and we'll start therapy. When you're considering treating a patient, there are the ATS-NTM guidelines that were regenerated or evaluated in July of 2020. And they give you some guidance on the medication regimens, the cocktail of medications, the length of treatment, and the surveillance that needs to happen to monitor these patients while they're on treatment.
And just to briefly touch on that for maybe those that are new to pulmonary or have not seen any or treated any patients with MAC, the reason we don't jump to treatment, and a great discussion that you need to have with your patients, because they will confront you that you identified what's wrong with me, you identified a bacteria, why aren't you treating me? And that is because it is months, if not year or more of therapy, and it's multiple drugs, multiple times a day with multiple side effects, including, vision loss. I've had 2 patients lose their vision on therapy. Luckily, both of them got it back when we stopped their medication. And hearing, hearing issues. Help me out, Jennifer. What else am I missing that are common side effects of therapy?
Well, you're just doing the big things that you touched on is visual changes, primarily optic neuritis, the hearing with the chronic macrolide use in the regimen, but just general intolerance of therapy. Some of them, they could have liver toxicity or renal toxicity depending on the regimen that they are on.
Right.
So it's really a collaborative approach with your patients, because the goal in all of this is to decrease their symptoms with treatment and get them to convert their cultures to negative. And so, the way the treatment guidelines outline the length of therapy is that our goal is to treat for 12 to 18 months beyond a culture that's negative. And then that means also that you're getting surveillance cultures monthly and want to document 12 months worth of negative cultures on therapy before you can stop that therapy. And this is a long haul, and that's a huge commitment for patients. But you want to be monitoring these patients and letting them know that you're in this journey with them, that you probably need to touch base with them on a regular basis, at least every 3 months, and or if they're having adverse reactions to medications. And what I hate hearing from a lot of providers is that the treatment's worse than the disease. And honestly, we don't have a crystal ball and we can't project how these patients are going to tolerate their therapy, but I almost feel like that's a cop-out. And just reassuring the patient that you're not going to put them on these drugs and you're not going to forget about them. And if they're having difficulties, you need to hear from them and you're going to help them navigate that process. Because we can make changes in their regimen and we can individualize that regimen to that patient so they can tolerate 12 to 18 months worth of therapy.
Okay. Let me ask you about kind of a common thing that we see in community practice where the patient had a chronic cough. They get a chest x-ray. It's not revealing. They go through all the therapies with their primary care. They're still not getting better. They get a CAT scan and they see tree and bud findings. And so then they usually get referred to us because of the abnormal CT and the continued cough. And we, as part of our workup, maybe we're able to get sputum out of them. We're able to identify mycobacterium avian. And, but the patient, otherwise, the cough is managed maybe with, some other anti-mucolytic therapies and, some other things. They're not losing weight. They seem pretty stable. Are those patients that you guys are considering treating, or are those patients that you approach with wait and watch?
Yeah, that's a great question. And those are the kind of patients that we like to get to see earlier so that we can do that surveillance with the patient. The NTM guidelines does discourage watchful waiting. But when you put that into context, they don't just want you to forget about this and get a new CAT scan in a year or not talk to the patient if they have new symptoms. So, I think it's okay to do watchful waiting in those patients, but you should still be seeing them. Our local patients we see every 3 months. You should, query them on how they're actually feeling. Are they having more symptoms? Is there a change? Do we need to kind of reassess by getting new sputums and kind of revisiting a new CAT scan to see if there's any progression of disease? But I honestly think that is a great scenario to actually just do some watchful waiting, but with very close surveillance.
Because the biggest concern is they could not only just have progression of more aggressive infection, but that they then develop bronchiectasis, which there's, no coming back from in those patients.
Yeah. And, bronchiectasis by definition is just airway inflammation and scarring, but that makes that patient vulnerable to any kind of bacterial infections. So doing that close surveillance would be important. So say, for example, they're feeling well one day, but they're not the next day. That's not what I think of as mycobacteria presentation. Mycobacteria is a longer trajectory of symptoms. 3 months from now, I notice my cough is getting a little bit worse. 6 months from now, I've kind of lost my appetite. It's just this longer presentation. But if I feel well one day, not so much the next day, that's where I think the provider really needs to kind of reassess that patient, get a respiratory culture to see if any other pathogens are causing issues for that patient, such as Pseudomonas or staph or, things like that could be targeted in that patient. I would discourage people from treating symptoms because we want to reserve antibiotic, do some antibiotic stewardship, which patients love. But we also want to preserve the macrolide in a patient who has grown or cultured mycobacteria in the past, because that is the backbone of therapy for mycobacterial treatment, particular Mycobacterium avian. So we do want to be a little bit cautious about throwing antibiotics at them. I'd rather have data and know what I'm treating so that I can get that patient through that. You also need to know that the courses of antibiotics should be extended in somebody particularly with known bronchiectasis. So it probably would be 2 to 3 weeks would be recommended for that patient.
Excellent. Yeah, those patients definitely are at risk for secondary infections, and it's really easy to get anchored that, they've got mycobacterium and not think about all those secondary infections that can come in. So I'm glad you pointed that out. So let's say they are on treatment and they're having side effects, and we're trying to maybe encourage them to stay on therapy because maybe they've got a very bad case. They've got extrapulmonary disease, or they've got abscesses or that type of thing. How do you guys manage their side effects?
That's a great question. When I initiate therapy, I don't start all the medications at once. So I'll stagger start them. So say, for example, we are treating Mycobacterium avium and it's a 3-drug cocktail. do them in alphabetical order. So the recommendation is for a macrolide, like azithromycin. And we choose azithromycin over clarithromycin because it is much better tolerated. So I'll start with that, and I'll give that patient direction to take it for 3 to 5 days. If they tolerate it after 3 to 5 days, then I'm going to add the next medication in alphabetical order. That would be ethambutol. So now they would be taking azithromycin and ethambutol again for 3 to 5 days. And if they tolerate that 2-drug regimen, I'm going to add rifampin. Out of all of the medications, rifampin is usually the targeted drug to have the most side effects. So I do encourage the patient to maybe take their rifampin later in the evening prior to going to bed, so that if they experience any of those side effects, particularly fever, muscle aches, body aches, that they sleep through that. Now, at any point, they could be 3-6 months into the regimen and they could start having side effects as we're loading more drug into the system. You sometimes have to address those side effects and say, oh, I think this is rifampin related, maybe because they're having high fevers or myalgias, and I will take rifampin away. And if they do fine, then we've targeted that rifampin and they may not be able to take that drug. And we may have to think about plan B and a secondary regimen for that patient.
Excellent. I like that. Do you also recommend that they see an ophthalmologist or have any follow-up there for just screening for vision or hearing issues?
Yeah. So chronic use of a macrolide can lead to hearing changes. So audiologist or audiograms should be done. And we do recommend that on 3-month intervals for the patient. I think E for eyes. So ethambutol is the one that can cause visual toxicity or what we call optic neuritis. And so again, establishing at baseline what their visual acuity is, and then every 3 months, and or if the patient experiences any changes in their vision. And I also empower the patient to say, ethambutol can change your vision, and the aging eye can have all other sorts of problems too. But if it's a Friday afternoon and you can't get in to see your eye doctor until next week, stop your ethambutol until you can talk to a provider about that.
Excellent. That's very, very helpful. I appreciate that. I like the nighttime rifampin. That's a good, in public health, we used to have our TB patients, do that too, when we would treat them. So next question I have is about reinfection versus reactivation. I know there's some discussion, or at least there used to be some discussion about that. I'm probably out of the loop. But patients would be terrified to take showers, after they were treated and they had negative sputums because they knew the hot water was going to be aerosolized and they were going to inhale it and they were going to catch this bug again. What do you talk to patients about that and their risk of becoming reinfected, or is it a reactivation of the bug?
Yeah, and I actually don't really like the term reactivation. I kind of prefer sort of relapse or reoccurrence. And, the only way to determine that is to actually get a DNA fingerprint of their organism, which labs can do. Our reference lab can do that. I don't know if it actually really is that important, but we always have to keep in mind that the underlying vulnerability in a lot of these patients is their airways, and it is bronchiectasis. And that bronchiectasis is not going away. So once that is there, it's always going to be there, and that is going to make them vulnerable for whatever term you want to use: reinfection, reoccurrence, relapse. Patients are obviously anxious about this, but we have had people on good therapy, and we've said, well, why don't you take a bath instead of a shower? And it made no difference in their care. We weren't able to convert their cultures. Probably it was the burden of disease that was more the factor than than anything else, or, made it then unable to clear their cultures. So I kind of step back from that, and I counsel patients by saying, if I knew what it was to ultimately protect you from this, I'd be sharing that with you. Mycobacteria is all around us. You should use some common sense. So what we do know is that charcoal filters do not filter out mycobacteria. So you think about, Brita filters or your refrigerator filter. So if it's reasonable to boil your water and put it in a glass pitcher in your refrigerator and drink off of that when you're home, that may be a reasonable thing for you to do. When you go out to a restaurant, you have to think about ice cubes and, things like that. And you're going to have exposures even in your day-to-day life that you don't even know you're being exposed to those things because it's all around us. And we can't put you in a bubble and protect you from all of this. And if you go to such extremes, you can paralyze yourself in your lifestyle. And nobody wants that because you still need to be living. And this is a chronic disease process. In most cases, we don't know why they have it. And so I think people need to live their life within reason. And if there are certain things that they feel are reasonable to do in their lifestyle, I think that's fine. But they do get fairly anxious about this, and it can become very consuming for them.
Yeah, it definitely can. They're very almost traumatized, over it, knowing that they're vulnerable to it and living with it going forward. I just want to touch on one more thing and I will let you go. And that is symptom management. So maybe your patients who are on therapy, what do you guys do to help them with their cough and sputum production, weight loss? Are there certain recommendations that you make for your patients who are actively being treated?
Yeah, that's a great question. And, fortunately, I have a very collaborative team. I have at my fingertips respiratory care to kind of work with patients regarding airway clearance. And that's really the foundation of care, especially if the patient has underlying bronchiectasis. We start with an aerobica or some kind of flutter device. As well as hypertonic saline to infiltrate the sputum to thin it out so that they can mobilize those secretions. And it's kind of twofold because not only are you achieving maintenance for their underlying lung disease, but you're also teaching them how to self-induce a sputum. Because when patients are on treatment for mycobacteria, you should be getting sputum surveillance very regularly, at least on a monthly or bi-monthly basis, so you can determine when they turn culture negative, because that does have implications. The weight loss, having a nutritionist involved in their care, because a lot of times patients have different diagnosis like heart disease, and they regulate or restrict, sodium and fats because of their cardiac diet, or they may have reflux and they're just being so restrictive that they're not getting enough calories to help. And so having that nutritionist help them navigate that is really, really important. So, I think it takes a village a lot of the times, and I know resources can be limited, but I think that's really helpful, in these chronically ill patients, for sure.
Excellent. Well, Jennifer, I really appreciate you sharing all of your knowledge about this bacterium with us. I think we have a better idea about it, and definitely I encourage everyone to look in their areas to their university systems and tertiary care centers for mycobacterial centers. Those are out there. I think that was always a shock to a lot of people initially that, we don't have to send directly to infectious disease. We could actually send to a center that is just seeing these patients. So being able to hear from an expert like yourself is so valuable. And I really appreciate you coming on today.
Sure. Thank you for having me. And again, I'm always welcome to help my peers help patients navigate this kind of complex chronic disease process, for sure.
Excellent. All right. Well, thank you guys for listening. Please like, subscribe, follow APAP on whatever platform you're listening to us on. It's the best way to help support the organization and this podcast. And we will talk to you guys again later.